Welcome everybody to the webinar entitled Navigated Laser Retinopexy with the Navilas System. My name is Eugene, and I'm going to be sharing some practical thoughts with you today and some real-life cases. I work at the Institute of Eye Surgery in Ireland, and we have two Navilas systems that we use for retinopexy and other macular treatments. These are my financial disclosures. So a recent publication from the UK has suggested that there is an increased frequency of retinal detachments. They attributed this increase in retinal detachments to an aging population and an earlier age of cataract surgery. However, most of the retinal lesions that we treat are associated with a posterior vitreous detachment. And as we can see, the incidence of rheumatogenic retinal detachments, according to our Dutch colleagues, peak when patients reach their 5th decade, right up to their 7th decade. And this coincides nicely with the incidence of a posterior vitreous detachment. So what I'm going to be concentrating on today is the use of laser retinopexy to treat peripheral retinal holes, breaks, and tears. These are the types of lesions that, if left untreated, could result in a rheumatogenic retinal detachment. We already know that during surgery, laser retinopexy is used to treat the offending breaks as part of retinal detachment surgeries. I would like to share with you some interesting, very topical and recent data. This data shows the increased failure rate of laser retinopexy during the 3 months of COVID lockdown. Our colleagues again in the UK suggested that the impact of COVID-19 on primary retinopexy has resulted in a significantly lower number of laser retinopexy performed in the 3 months during lockdown compared to the same period in the year before that. As a result, the 3-month retinal detachment rate during the COVID period is significantly higher. Therefore, it's still very topical that laser retinopexy is effective in preventing retinal detachments. So I would just like to share with you my personal experience with the Navilas system in performing laser retinopexies. We have approximately 182 patients treated between March 2019 and November 2020. They are mainly for tractional retinal tears or holes. Very few number of shallow peripheral retinal detachments, and also lattice degeneration with atrophic holes in the absence of posterior vitreous detachments. These are obviously particularly pertinent in patients' fellow eyes where their first eye has already developed a full retinal detachment. I would also like to share with you then the parameters we use for laser retinopexy. And I would like to share with you a very complex case demonstrating every single one of these lesion types that I've just discussed in this slide. So firstly, we use a 300 spot size. The reason 300 is because the Navilas system calculates the approximate spot size at the retinal plane from a contact lens that we choose on the system. And this depends on the type of contact lens we use. So for example, if we use an ocular mainstar PRP lens, then approximately the spot size would be double on the retinal plane. So the 300 spot size is equivalent to approximately 150 micron spot if a slit lamp laser was used. I use a 20 millisecond laser duration. This is the shortest practical duration in order to achieve a high enough laser power without reaching the threshold of the maximum power afforded to the Navilas system. This duration was kept low because the shorter the duration of a particular pulse, then the shorter of the total treatment time duration. And we also know that the shorter the treatment duration, the more comfortable patients are going to be. With a smaller spot, there's also less thermal reaction to the tissues beyond the fluent spot. I also do not overlay spot on top of spot. I leave a quarter spot size distance between spots. So this provides a near confluent treatment. It prevents overlapping burns, and it also decreases the total number of spots because I'm able to treat a larger area with some spacing between spots. So that decreases my treatment time by 25%, but it also decreases the total energy delivered to the retina by 25%, so far without compromising on the spot intensity and the efficacy of the treatment in totality. The average power used in my patient cohort is approximately 370 milliwatts. This is obviously different depending on the pigmentation of fundus that is geographically different from country to country. The range obviously stretches from 200 to 1,500 milliwatts depending on fundus pigmentation, and the choroidal blood flow below the area of treatment pretty much the same as traditional slit lamp lasers. So there are several criteria when we look at in deciding whether a particular laser platform is suitable for laser retinopexy. The first one is whether or not the laser can get us out far enough to the periphery. The reason for that is because most retinal pathology that requires laser retinopexy are in the periphery of the retina. If you can see on the schema of the eye on the right-hand side of the slide, there is approximately a 6 millimeter distance between the equator to the ora serrata. As you can see on the left, this is the treatment plan on the Navilas. The red oval denotes the vortex veins and ampulla, and the white line denotes approximately where the equator of the globe is. So as you can see, the treatment plan traverses the equator. And if I tell you that I'm using a 300 spot size with a quarter spacing, then the width of the retinopexy is approximately 1.1 millimeters. So that blue arrow is approximately 1.1 millimeter. If you extend that 6 times, you get approximately 6 millimeters, which brings you approximately out to the ora serrata. In the earlier days of using the Navilas laser platform, I wasn't sure if my treatment profile was peripheral enough, so I used to indent most of my patients, but I've stopped doing so after realizing that if I can get as far out to the edge of the lens, that I'm essentially treating out right out to the aura. And in even some patients, depending on the optics of the eye, I'm actually able to get beyond the ora serrata. So the next question we ask ourselves in choosing a laser platform on whether or not it is suitable for laser retinopexy, we would like to ask our system to be able to treat complex cases. The reason for that is because most units, unlike ours, can really afford to have only one laser system. So it doesn't make sense to purchase a laser system if it can't treat all retinal pathologies. So here I would like to share with you a case of a patient's right eye with a massive tractional horseshoe tear supratemporally, as you can see, associated with a cough of subretinal fluid. This is approximately about as much subretinal fluid as I'll tolerate before considering surgery. So in this case, you can see that we performed a laser barrage, and in the lower left corner, that's the treatment plan that the Navilas was used to drive this treatment plan. As you can see in the patient's fellow eye, there are very large atrophic holes adjacent to areas of lattice. Because he has not developed a posterior vitreous detachment, we elected to prophylactically treat these large holes. And again, below, you will see the treatment plan afforded by the Navilas laser treatment. On the upper left slide, you will see early treatment uptake of the laser. on the upper right slide, you will see the untreated Whitfield image on the Optos imaging system of where the lattice is. At 2-year follow-up, you can see that the laser areas are now heavily pigmented, usually signifying a sufficient laser uptake over the areas that were treated. The area of retinal detachment was successfully held in place. There was no progress in the area of retinal detachment in the right eye. And so far, there is no retinal detachment in the patient's left eye, in spite of developing a posterior vitreous detachment, as denoted by a vice ring over the disc. You will see on the wide field swept source OCT afforded by this combined Optos system that there is no epiretinal membrane. A common feature usually that we see in patients that we either over laser or has resulted in a significant inflammatory response following laser retinopexy. And the last question in asking ourselves whether or not a system is suitable for laser retinopexy is the efficiency of the retinopexy itself. How quick and how comfortable is a particular laser system when treating laser retinopexy? So this is a live video of the screen of a laser retinopexy that I performed a few days ago. You will see in the middle of the slide, again, an ultra-wide field imaging of the same eye, showing a tractional hemorrhagic horseshoe tear on the supratemporal arcade. This happens to be at the aura. As we can see, it's just over the ampulla of the vortex vein. So first we pick a contact lens. We apply the contact lens on the eye, just like any traditional slit lamp. We capture a reference image. We attach 2 caution or no-fly zones where the laser wouldn't fire. We plan the treatment in 2 arcs because the power required in the periphery is different to the power required posteriorly. The power required peripherally on the Navilas system tends to be higher than the laser required posteriorly. So this video does not even last a minute, and this is an unsped up real-time video, and it allows you to capture a copy of the retina after the procedure so that you can document that the laser was completed. So since the adoption of our Navilas system in March 2019 for laser retinopexy, we have not had to use other laser systems. And in fact, we have only recently acquired our second Navilas system very recently. So we have not had any other laser systems available to us and have not had any need to use any other laser systems to perform laser retinopexy since having our Navilas system. There's definitely a quicker patient turnaround time due to more comfortable treatments and far quicker treatment protocols, allowing for patients to be treated in a shorter space of time. On the Navilas system, because it's digital, it's also easy to assist colleagues to convert to a Navilas treatment platform because they see exactly what I'm seeing and they see the treatment in progress, and we are able to treat patients together. There were no patients that were converted to cryopexy. However, obviously lesions that are extremely peripheral, I've opted to treat with cryopexy instead. And certainly there are patients with vitreous hemorrhages, which would make laser uptake difficult. And again, these patients would be treated with cryopexy. Anytime the view is too poor, I would elect to treat them with cryopexy with very careful indentation. And if the view is still very poor, then I would probably elect for vitrectomy to ensure that I do not miss any breaks. There's been one eye that progressed to a retinal detachment requiring surgery. and one eye developing a visually significant epiretinal membrane, which was again surgically removed. So just some tips for existing Navilas users. I tend to plan 2 separate arcs instead of one full circle. The peripheral half invariably require more laser energy, and that's due to the peripheral aberrations afforded by the Whitfield contact lens. I toggle between the infrared illumination and the visible light illumination in cases where there is difficulty in locating the tears. I use 3 rows of laser. This I have found to be adequate. This can obviously be increased right at the aura if you're unsure that your anterior treatment is sufficiently anterior. And I use at least 2 no-fly zones or 2 caution markers, and that assists with tracking of the retina. I tilt the lens towards the location of the pathology, and that allows me to get as far peripheral to the ora serrata. There is also a non-contact lens, and the Navilas call this a PRP lens, which I have used occasionally, but only suitable for very posterior tears. Lastly, I would like to thank you for listening to this webinar.